All right, for the sake of time, maybe we'll go ahead and get started. I want to make sure to give folks a couple minutes so that you can have a restroom break before we return to the main session at 5 minutes after the hour. But my name is Adrienne Simmons. I use she, her pronouns. I am the Director of Programs at the National Viral Hepatitis Roundtable. We are a national coalition of patients, providers, community-based organizations, and public health partners, all working together to eliminate viral hepatitis. And so we're super excited to be co-hosting this summit with Community Liver Alliance. My colleague Dana Raymond, who you've heard from a couple of times today, has done a fantastic job, I think, in putting together this summit, and hopefully you've learned something new. I know that I have. I have the pleasure of moderating this breakout room and then providing a report out. And the topic is hepatitis C treatment among people who use drugs in Appalachia. I am a pharmacist by training, so certainly this is an area that's of interest to me, but perhaps most relevant is that part of our work at NVHR is to track prior authorization criteria in state Medicaid programs for hepatitis C treatment. And so we've heard a lot today about some of the challenges with treatment, one of which we just heard about in West Virginia, specifically related to prior authorization criteria. And so I want to spend some time just opening the floor perhaps on hearing a little bit more about what challenges you're seeing in your communities. But the ultimate goal of today's breakout session is for us to come up with 3 key recommendations to improve hepatitis C treatment for people who use drugs in Appalachia. So ideally, that's what we'll walk away from this breakout room with. If we end up with extra time at the end, there's some follow-up questions that I'll post to the group around what stakeholders need to be involved to implement these recommendations and whether there are policy changes that are needed. But to start, I'm just going to open up the floor to folks for maybe the next couple of minutes, just to share a little bit about what the challenges are. And then from there, we'll transition into asking for recommendations. And I'll share my screen as I take notes. So the floor is open. Would anyone like to start in sharing a little bit about challenges you've seen with hepatitis C treatment for people who use drugs in your community? So to recap a couple of the things that we've heard so far, we've heard prior authorization challenges, and that can cover a whole host of issues, from requiring a specialist to prescribe treatment to requiring 2 RNAs within a certain period of time. It also includes things like sobriety restrictions, so requiring that someone abstain from substances for a certain period of time before they're eligible for treatment. So I've made note of the prior authorization challenges. The other thing that I recall hearing is the need for rapid diagnostics. And so Nick Voiles did a really nice job highlighting the challenges, particularly within harm reduction organizations and people needing to come back multiple times in order to be diagnosed. And so typically, people get an antibody, they need to then return to get their RNA, and usually they have to return to get those results and then be referred somewhere to get treatment. And so there are lots of barriers that people have to overcome in order to even be referred to a prescribing provider. So certainly rapid diagnostics and prior authorization challenges are 2 things that we've heard today already. Are there other challenges that you're seeing in your communities?
I can say I'm with the Department of Health out here in Virginia, and I'm the hepatitis C regional coordinator. So I do a lot of case follow-up, and I think a lot of the barriers that we see is just getting in contact with people. because if people are homeless, they don't have mailing addresses, or if they don't have a reliable phone number that we can be calling them with. So I think that's a big barrier that we face, just even that first step of getting in contact with people who need the treatment. And I think a workaround with that would be much more partnership with other community organizations who could provide those resources, who could provide, a mailing address or cell phone that they can get some minutes on, so that we could get in contact with them.
Awesome, thank you so much. Other thoughts? I'm going to share my screen here. I'm just taking notes on a platform called Padlet. Attempt to zoom in, maybe. There we go. So on the left-hand side of the screen, you'll see that I'm just jotting down some notes around challenges. And then in the next column, we'll start thinking through what our key recommendations might be. So far we've got prioritizations, rapid diagnostics, and getting in contact with people. Other thoughts?
I guess, and I know it's been touched on, I guess the thought I have too is just really addressing the inconsistencies related to, lost my train of thought. Oh, related to sobriety restrictions or lack thereof, even if, because we know that there's a lot of inconsistencies around doctors' practices for prescribing, even when there are no restrictions, they still kind of have self-imposed restrictions, or if there is guidance around this, it's not always consistently implemented. And so there are still barriers for people to receive treatment, even in places where there are technically no sobriety restrictions related to just kind of independent attitudes of providers in relation to prescribing and concerns around reinfection.
Thanks, Sonia. Yeah, I think that's a really important one, and agree that it should be broken out from sobriety restrictions. And really the best way perhaps to summarize it is stigma or provider bias. And so we've definitely seen, I've worked with McFoyle's, even in Indiana, and the state Medicaid program didn't have any sobriety restrictions, but there were providers in his community that would deny treatment to people because they were self-imposing sobriety restrictions, even though their insurance company wasn't requiring that. So that continues to be a big challenge, and we've heard a lot about how stigma might manifest among other providers like pharmacists as well, and trying to access things like medication assisted treatment. So stigma and provider bias is definitely an important one. I know that we've had a couple other folks join us. Right now we're just spending some time talking through challenges related to improving hepatitis C treatment for people who use drugs. At this point, I think we should transition into what the goal of this breakout room is, which is really to walk away with 3 key recommendations to improving hep C treatment for people who use drugs. So just to recap, for those of you that just joined, some of the challenges we talked through were prior authorizations, the need for rapid diagnostics, being able to get in contact with people, so having accurate, up-to-date contact information, and then finally stigma and provider bias. So now we'll transition into some recommendations, and we'll kind of brainstorm a list. If we get more than 3, great. We can then talk through how we'd like to narrow them down. But one that I've already heard is, as it relates to getting accurate contact information for people, would be to partner with community-based organizations to get updated contact information from folks, like mailing addresses and phone numbers. The floor is open if other folks would like to chime in with some recommendations on how to improve hepatitis C treatment for people who use drugs.
Well, hey, I'm Tammy Gospel. I'm with the University of Kentucky. I think the key, at least for our patients, are continuing to use telemed services. And pretty much now we can use telemed for all treatment. They have to go locally for labs, but we can treat anyone in the state of Kentucky via telemed with our providers. And so, but I do know since the pandemic started to wane, the first 3 times, at least a lot of providers in Kentucky have gone away from telemed. So I do think that that's important to keep that.
Yeah, I think that's a great idea. Thanks so much for adding that. That's disappointing to hear that people are already starting to move away from it. The very opposite of what we would hope people are doing. But I agree. I think it's been a really great way to increase access and has been perhaps the only silver lining that has come out of the pandemic. So that's great. Other thoughts?
This is Darcy. I think it was mentioned a couple times by different speakers talking about prescriber restrictions, that Medicaid requires a prescription to be written by a specialist, which in rural areas can be proven difficult if there aren't enough specialists in the area.
Yes, I think that is critically important. I'm gonna maybe even broaden this one to say removal of, or be a little ambitious here and say removal of prior authorizations. And I'll put a note under here just to highlight the fact that the specialist requirement, in particular in Appalachia, is a really is a large barrier. But we're going to be bold and say let's just get rid of prior authorizations altogether, which has happened in 8 states to date. Have removed prior authorizations for hepatitis C treatment. As I'm thinking through the states in the back of my mind, none of them actually fall in Appalachia, but Virginia actually will be removing prior authorizations effective January 1st. And so perhaps that will encourage some neighboring states to consider the same. But agree, that's a really, really important aspect of this. Other thoughts? So one that I'll add here, and that I think is really timely in the context of a meeting that happened just a few weeks ago, is related to the need for rapid diagnostics, which we heard again from Nick, very loud and clear that this is a huge barrier for rural areas as well as for community-based organizations. And so just a few weeks ago, the CDC and the Association of Public Health Laboratories jointly held a meeting to talk about this very topic. And the good news is that there are rapid diagnostics available in other countries. And so there's a company called Cepheid that makes a machine called the Gene Expert that would allow you to get an HCV RNA within minutes. And so this is being widely used in other countries, but is not approved by the FDA in the United States. And so there are some other testing mechanisms like dried blood spot that are also being considered. But really the community has to make the case for why these diagnostics should be brought to market in the United States. And I'm glad that our federal partners are having those conversations. I do know that the recording of that conference is going to be shared in the near future. I believe there's going to be an executive summary that's shared in January of the findings of that committee. But I'll just add on here that needing to bring to market rapid diagnostics so that we can start, we can simplify the diagnosis process and start people on treatment the same day that we diagnose them is critically important. We've got about 10 minutes left. Other ideas around key recommendations to improve Hep C treatment for people who use drugs? To recap, we've got telehealth, removing prioritizations, rapid diagnostics, and then partnership with community-based organizations. So we've got 4 recommendations so far. Certainly, if you all have other ideas, feel free to chime in. But in your opinion, do any of these rise to the top more than others? Our goal is to narrow this down to a list of 3. So if anyone would like to make the case for prioritizing 3 of the 4, the floor is open.
I would say it's cut off on my screen, but the stigma provider bias one, the one that I had mentioned around, I think that should be among the top priorities. I think that, as well as the rapid diagnostics, particularly for people who use drugs, that way you can really just get them engaged, get them aware and get them engaged as quickly as possible. And there will be less loss to follow up.
Sonia, may I ask a follow-up question on the stigma and provider bias
Sure.
challenge, which is that, and this question's open for the group, but are there any recommendations about how to address stigma and provider bias? I can certainly write address stigma and provider bias, but do we have specific recommendations?
I think one of the things would be just some sort of this isn't going to be very articulate. Because I know, like, for example, there are some it kind of runs a continuum, but there are some, again, some locations where, legally it has been removed, but, in practice, there's still a lot of individual. So some sort of guidance or some sort of standard, have Nick scare them straight. Yeah. But yeah, some sort of guidance, document and some sort of standard accompanied by training. It's like the first place that I land. And I'd have to think through any other kind of solution.
Is there, this makes me think back to the statement that came out related to hepatitis B, I believe from HHS and the Department of Justice, about discrimination against people living with hepatitis B within employers, the military, and then health professional schools, which I think was the focus of this letter. They sent this letter to health professional schools and basically said, you can't discriminate against people living with hepatitis B. And so I wonder if there's opportunity to bring in even our federal partners, or maybe on the state level, it's sending a letter to all the Medicaid providers about stigma.
I agree with that. I think it needs to come from as many different angles, kind of a consistent message coming from as many different angles as possible. With a consistent message. But no, I think coming from the federal partners, it'll be a great idea.
Awesome. I'm going to put anti-stigma campaign for providers as the kind of catch-all recommendation. I see a comment from Sherry to advocate for including telehealth as one of the top 3. We've seen during COVID how powerful of a tool it's been, but when the pandemic ends, not all states are keeping the broad-based that we use today. The broad-based use that we have today, that was a tongue twister. So it sounds like there's interest in putting anti-stigma, rapid diagnostics, and telehealth at the top. Are there others? The other 2 that we have is removal of prior authorizations and partnering with community-based organizations to collect accurate contact information. I'm certainly biased in suggesting that prior authorization removal be a top recommendation. So I will look to someone else to suggest that before moving it to the top.
Hey, this is Jessica. Sorry, I joined a little bit late. I would agree with that.
to include prior authorization. I think another key recommendation is just to make sure that there is access to hepatitis C treatment in harm reduction centers or substance use disorder treatment centers. I've heard certainly that there's barriers to reimbursement for certain types of providers. So it's not always even accessible in the first place in areas where people who use drugs are at.
Thanks, Jessica, and thanks for joining us. So I'm going to summarize this by saying increase access to Hep C treatment in harm reduction settings and other settings that serve people who use drugs.
Yeah.
What else? And Sherry, I see your other comment that we haven't seen treatment increasing yet in states who have removed prior auth. We're watching it, but haven't seen it in the data yet. And I also think that's certainly skewed by COVID, but it's multifactorial in the sense that states also have to communicate that these policy changes happen. And so, you know, even we spent a lot of time during the summit today. We heard a lot about challenges in West Virginia, and I was just doing some digging as I was listening, and it looks like West Virginia updated their prior authorization form, and one of the issues around 2 RNAs may not be an issue anymore. But if Medicaid programs aren't reaching out to their community and the providers and letting them know this, even in states that have removed prior authorizations, there isn't always a concerted effort to communicate that change to the people that are prescribing or the patients that would be accessing care. Then certainly we will see a lag in those numbers as well. So definitely multifactorial. We've got about 2 minutes left. What do we want to finalize as our top 3 recommendations? I promised that I would give folks a few minutes break before we go back to the main session in case you need to use the restroom or grab coffee. But any last,
Adrian, what about also adding, I don't mean to add now this late date, I came in late also, I couldn't get out of the music, I couldn't hear you. Anyway, about more GPs being able to prescribe and treat, and that goes right hand in hand with prior auth to me, I think. And didn't West Virginia say they still have that limitation?
Yes, you're absolutely right, Deb. And we went even, we were bold in our recommendation here and suggested the removal of prior authorizations with just a note that the specialist requirement is particularly challenging for rural areas. So I think you are spot on with that recommendation. So I'm going to move, let's see, I'm going to move that up. So we've got telehealth. I think the things that we need to, in terms of our last, our third recommendation, the things that we're deciding between are anti-stigma campaign, rapid diagnostics, partnering with CBOs to collect accurate contact information, and then increasing access to treatment and harm reduction settings. Do any of those resonate with anyone to be our third and final recommendation? Okay, hearing none. I'm going to recommend that based on, maybe I'll just provide more than 3 recommendations. How about that? And we'll try to help the folks that are organizing kind of the summary document from this. But this has been really helpful. I appreciate all the discussion. We are right at time. So in order to return back to the main conference platform, you're going to click the live stream button in the upper right hand corner. to resume the stream. I do believe we've got a few minutes before the report outs will start. So certainly if you need to go use the restroom, please do that. And if you have any questions navigating back to the main screen, just let me know. But David is also here to help. So thank you guys for joining us, and we'll see you back in the main session.